Hi everyone. Welcome to Reality Team Conversations. I'm Deb Lavoie. I'm the founder of Reality Team, and today we're going to talk about some really challenging and complicated issues in hopes that we can understand a way to appreciate some of the sources of medical and other kinds of mistrust that make people hesitant about taking vaccines, particularly the COVID-19 vaccines. We are going to be talking to Rachel Lee Carey, who is also on the Reality Team. She leads our content on healthcare issues. And a few weeks ago, she made a really interesting observation, noticing that the language she was hearing from her sort of friends, acquaintances, and family expressing concerns about the COVID-19 vaccine were nearly identical to some of the language that she was hearing in the clinic where she volunteers. So she's brought two people from that clinic, Kristin Moltz, who's the medical administrator and coordinator of medical students there. Hi, Kristin. And Shantae Rodriguez, who is the director of women's health there, to talk to us about the kinds of medical mistrust they see in their patients and some pretty sophisticated protocols for dealing with it. So first of all, thanks for being here, Shantae and Kristin. I really appreciate it. Rachel, thank you for sparking this conversation. I want to start real quick. Rachel, talk a little bit about what you were hearing and how we got here.
Yeah, so it's been a little complicated. So of course, since COVID-19 started, there's been a lot of misinformation, and we've been seeing a ton of disinformation coming in about the disease itself. But then once the vaccines started coming out, we're seeing just an exponential explosion of disinformation. But besides that, I noticed like there was a real hesitancy in the communities, particularly like, my family's mixed, Black, and my community, my friends, I have, a lot of Black friends and minority friends, Latinos and stuff like that. And what I was noticing is that a lot of the language around vaccines were phrases like, oh, I'm not letting them experiment on me. Or, I don't want to give so much control to like the government to just tell me what I have to do or what and what I need to do with my body. And it was just a very interesting that the tone and the phrasing was very fearful and centered around what do people get to control about my body, what say do I have, and then this thread of just distrust and medical distrust, which is not uncommon in minority communities, especially in the Black community and the Latino community. But I did notice that the particular phrasing was part of a lot of the language I was hearing in my training. So what Shantae and Kristin do, besides being amazing fantastic clinicians, is they actually train all of us as staff in trauma-informed care. And a lot of the language was very similar, like language that they're saying like, oh, these are cues you need to pick up from your patients, or things you might want to be careful of about, when your patients start speaking. This could be indicators that they've experienced trauma. And I was like, this is the same language that I'm hearing from my friends and my family about why they do or do not want to take the vaccine or something like that. And I just thought it was very interesting that this was such a close parallel. And one of the things I started thinking of is like, okay, well, if you have a lived experience of being in this country and having tons of microaggressions and racism, you are actually probably traumatized. You have significant levels of trauma. But then specifically when it comes to the medical institution and looking at the history of the medical institution and how it's related to minorities and how it's related to, the Black community and the horrendous experimentation and like, things that have happened, I was like, what we're looking at is an abusive, like an abuser and a victim relationship. And basically the medical community is coming to the victims saying, we know what you need, and not acknowledging or accepting that the abuse that's been heaped on these people for hundreds of years has culminated into a cultural distrust of the medical community in general because of trauma.
I'm hearing what you're saying, because we've talked about this a little bit offline too. You saw this language that sounded like the language of trauma that you study in the clinic, right?
Right.
And we've spent a lot of time looking into, and you as sort of our guide, understanding the history of medical racism and the current present day existence of medical racism, and how that manifests in the world. And you drew a connection between seeing the insults of racism as being a form of abuse, and seeing this connection between being the victims of racism and being the victims of abuse and the trauma that comes out of that.
Right. So specifically, like if you were, there's the general idea of just like, being a minority in America and having these levels of microaggression and daily, like, incidences that would give you both specific trauma of things that you've lived through, but also this ambient stressor of a consistent undertone of racism throughout the country that would give you these ambient stressors that could trigger trauma. But then when you're looking at it specifically from the point of view of a patient who is a minority, then walking into the medical establishment, this history of medical racism specifically might trigger like a traumatic experience, and therefore give you all the symptoms of trauma, which Kristin and Shantae have a much better handle on what that actually looks like in the clinical setting. But there's a lot of, I was seeing a lot of parallels, and that's what kind of made me think that this is something that we should look at. So
you invited Kristin and Shantae, and who are practitioners and experts, people who treat people who are experiencing trauma, traumatized people all the time. So thank you for coming and talking to us, Shantae and Kristin. Really appreciate it. Can you tell us a little bit about the types of patients and the types of traumas you see in the clinic?
Sure. So essentially right now we are dealing with women who have come out of trafficking or domestic violence situations, and so would have had a extensive background of some sort of abuse or trauma. The couple of organizations that we work with currently deal with foreign-born, and so not only are there these traumatic experiences, but then it's also being of non-US citizen. Or that in the process of becoming a citizen through, one of the visa processes or other means.
And when you hear the kind of language that Rachel was talking about, that she was hearing from her friends in her community, does that sound familiar to you, or do you see the same connection that she does?
Yes, and so it's a matter when you just talk about control. Right. And so in trauma-informed care, one thing that you begin to teach and one thing you begin to realize is and when I say we, I mean just to say medical professionals, right? We're in a position of power. And so whether which is a lot of time here, usually like, I won't wear a lab coat, or sometimes usually I won't even wear scrubs. We'll wear just very, comfortable clothes, or, professional clothes, but comfortable as well, because you're already walking into a barrier with somebody thinking I'm beneath them. Right? So you already have that portion of somebody who's experienced a traumatic relationship or a traumatic event or a traumatic life, now is already feeling I'm walking into a situation where somebody is already above me, right? That's already going to trigger the essence of control. And then now most time medically, you're going to walk into somebody and they're going to tell you, well, this is what's wrong with you. This is what we need to do. This is how we need to do it. And if you don't follow my plan, you're not compliant. Right? That's typically what happens when you go to a doctor, right? So here you have high blood pressure. I've taken your blood pressure. I want to start you on this medication. I'm going to see you in a month. And if you come back in a month, well, what do you mean you didn't take the medication? How's your blood pressure going to get any better, right? But throughout that process, what trauma informed teaches you is that it's empowering the patient to be able to say, where is it you feel as though you are? What is it you want to work with? And how can I, as your medical provider, help you reach those goals, right? So if I take that same scenario and say, I see that you have high blood pressure. Is this something that you think we can work on today? How are the steps in which you think to do that? Now, some people can say, all right, I want to try diet, exercise, or some people say, all right, I want to do a medication, but it's giving them the control. Instead of already walking into a situation and feeling like I'm above you and now I'm going to tell you what to do, which in any abusive relationship, that's the power and control cycle, right? It's you have no power, you have no control. You're going to do what I say, when I say, how I say it. And if you don't, there's going to be repercussions, right? So in the medical aspect, those repercussions are your doctor disappointing in you. Your doctor's going to yell at you. Your doctor's going to tell you, you know, you're being not compliant. Your doctor's going to tell you all the reasons of why it's your fault, why you're not getting any better, opposed to actually stopping, listening to where the patient is, and then understanding how can we team and go together. Not, I'm not leading you. I'm walking beside you and I'm saying, how can you get better? So the language in which Rachel was talking about when it comes to like the medical community and when it comes to trauma, it's feeling as though now here's somebody telling you what you have to do, when you have to do it, why you have to do it, without giving you any leeway into making your own decision as to what you want to do.
So
I think,
just
yeah,
go ahead.
sorry, the other piece on that is really approaching patients more with an approach of curiosity as opposed to judgment.
Right.
And so it's saying, where have you come from? What has happened to you that is making you resistant to this or making you biased against or for a certain behavior? And then as opposed to saying, why are you non-compliant?
Or what's wrong with you?
Or what's wrong with you, yeah. And so it's really a place of curiosity as opposed to judgment, and learning and listening to stories.
There's several things in the answers that you've just given me that I kind of want to ask more questions, follow-up questions about.
Sure.
The first is that it sounds like one of the key issues is that these people have learned to be distrustful of people who have power and or authority. And that relates to what Rachel said, but this is one of the key issues, is just this mistrust, right?
But I want to just say it goes deeper than mistrust. It's more of a malalignment in that trust. And so when somebody abuses you, when somebody controls you, it's not that now it's your fault you mistrust them. They've ruined that trust. They've taken that ability for you to be able to trust them because they're no longer safe. So it's not just a distrust, it's an abuse of the trust. And that's the portion that becomes the control. You've abused my trust that I've given you, so now I can't trust you. So it's not that I just distrust you because I don't believe what you're saying. I'm guarded from trusting you because you have the potential to abuse me.
So in some ways, what you just said is a perfect example, which is that it is not their fault that
Correct.
they're mistrustful, but something bad has happened. Someone has abused their authority or power and harmed them.
Correct.
Which makes them impossible to trust. And so as someone in a lab coat, you represent authority.
You represent authority. You represent power, but you also represent, you represent power on many different levels, right? You represent power educationally. You represent power financially. You represent power positionally. You represent power in so many different ways that when that person who has been abused, who has, you know, a host of trauma and insecurities and fears because of what has happened to them. Now I'm here on this level of authority in so many levels in which their life is not stable, right? So someone coming out of an abusive relationship may not be financially stable, may not have had the opportunity to get educated or the type of education that they wanted, may not have a stable place to live, may not have any stable relationships. And so my position is kind of taking a hold of all of those realms. And so it's not just a vulnerability that they're walking into, hey, take care of my health. It's also the knowledge and respect, or sometimes what happens is in that abusive situation, it's triggering because it's now looking at, oh, this person has so many more levels above where I am. Yeah. You know, again, hence why, like, you know, when we're just medically with our patients, again, you know, we will, you know, sit down at the same eye level with them. We're not standing above them when we're talking. We're giving them space. You know, can I close the door? You know, before I even, are you comfortable with the door open? Letting them know from the moment they walk into our office, they are in control.
And this
my medical knowledge gives me the responsibility to keep them healthy. So I will guide their healthcare depending on where they are and what they need. But I will give them every option along the way to make as many as decisions that they want to make. And in that abusive control relationship, it's just the opposite. So when you hear things that sound reminiscent of, I'm taking away your choice, I'm taking away, you know, your control to do something, or I'm going to do something to you and you have no choice, that's where the triggering begins to happen.
And this is like, I would say, what she's describing is how we see it on like micro level in terms of daily interactions and social interactions we have with patients like that. But if you were to apply this on a macro level and look at it, the history and like the cycles of abuse that we were talking about in terms of medical racism, that's where the abusive relationship has come in, where you have like forced experimentation on people and where you've had forced sterilization, even up to, and this is like historical, but even currently there's been accusations of forced sterilization of minorities in ICE camps. And these are all, what we're looking at is now, not only are we, as you know, the medical team, the medical institution, we can't uncouple ourselves from that history because that's all part of the background of abuse that people are recognizing and understanding, and they're seeing it. And so we represent that as well, as on top of all the other, you know, financial, educational, power dynamics that come with being, you know, a medical professional. We now have this horrible history of explicit, you know, violence and abuse that we, no matter, you know, if we've participated in it or not, that's what we represent to people.
And I think it's also because it's been excused for some manner. So it's like, oh, we did this horrible thing, but look what's come out of it. You know, oh, you know, we did this, you know, horrible experiments on women, you know, but look at what came out of that knowledge. You know, we did these horrible experiments, you know, with syphilis on these, you know, on this population of men, but look at what came out of it. You know, there's always this flip side of, although this is really bad, look at the benefit that came. And so that's also some of that history that's built into, okay, well, I don't want to be a part of that anymore.
Even right. I find that terrifying.
I think most people find it terrifying when it's actually laid out. When it's laid out there, you know, it's the problem is, like, you know, Shantae, it's not only been excused, like she said, it's not only been excused, it's been it's been swept up under the rug in some instances where, you know, even 2 or 3 years ago, the thing she was talking about with women in obstetrics and gynecology, James Marion Sims, who actually actively experimented on, you know, enslaved women and without anesthesia and did all these surgical procedures so we could learn, like, that is the foundation of obstetrics and gynecology in America. That is that right. Like legacy. And we didn't, like, most people did not know about it until 2 years ago, 3 years ago. So it's been,
it's like epigenetic trauma.
it's an epigenetic trauma, and there are
Emotional
epigenetic
trauma.
markers. And another thing that, you know, that Kristin and Shantae have been teaching us is about, you know, what are the markers? If you saw somebody who was, you know, older and had been traumatized, there are some actual physiological markers that show up in their body and in their care. And it kind of, very interestingly enough, parallels what you're looking at with minority communities in terms of obesity, cardiovascular issues. Those are all the things that they are like, hey, you know, if you're seeing this and it's coupled with this, this might be trauma. You know, this might be somebody who's been traumatized. And if you're looking at, again, like if you apply it on a macro level, you're like, wow, that's an entire group of people.
Shantae and Kristin, let's talk about trauma. Obviously, trauma exists on a spectrum, right? What does that spectrum look like? What is the difference between trauma and distrust? Let's just start with there. What is trauma? What are sort of the end points of trauma from something that's relatively minor to something more serious? And how is the manifestation of that different? Well, you've already sort of answered this, but I'll ask that question separately. Talk to us about trauma. What is trauma? Where does it come from? How does it manifest in different ways?
Yeah. I mean, so if you think about just an overview of trauma, trauma is any life event that then changes your view of yourself, of your world around you, or your worldview, right? So again, I can have a car accident, right? That car accident to me is traumatic. And every time I step into my car, I may have, you know, perceived fear, right? Sexual assault, that obviously is a different spectrum of trauma, but trauma is individualized, right? So what is traumatic to one may not necessarily be traumatic to another, but also it's how trauma compounds, right? So what, like Rachel was alluding to earlier, like there's this study, like the ACE study, right? And it talks about how if you've grown up and had a certain amount of these like 10 points of trauma, and how many of these have been existent in your life is going to equal to your health outcomes as an adult.
So trauma is predictive of health.
Trauma is predictive of health, absolutely.
So just the ACE study, ACE stands for Adverse Childhood Experiences.
Yeah.
And they're pretty clear in that on saying that, you know, just having these experiences, if we're screening for them and calculating and adding up, does not necessarily equal the same result, because your response to the trauma is based on supportive adults who were around you at the time, supportive relationships, on there's just a lot of other things that if there was no one supporting you, it's a much more compounded trauma. But if you had one or two, a teacher or an aunt who was very supportive and who you enjoyed and had a good relationship with, your resilience and your response to that trauma is completely different than someone who had negative feedback from every teacher as well as every family member.
And
so
also
biologically,
biologically,
it's not necessarily directly predictive, but it does give us a clue as to where some things might be coming from.
And also depending on the type of trauma, the age in which the trauma started, you can have basically, I guess, to say it non-medically, you can have changes that begin to happen in your brain and the way that your brain develops and the way in which your brain actually begins to process information. And depending on the type of traumas and the compound of that trauma, as an adult, you may actually lack some of the actual capacities to make different decisions because of the way in which your brain developed. So trauma is extensive. It can be very mild to very, very, dramatic in its effect.
So right. So what you started out with is that trauma is when some life event has had a notable impact on your worldview, thinking, or behavior.
When it has a negative,
negative.
right? So it has a negative impact on you emotionally, physically, mentally, spiritually, financially, something that has a negative impact.
So that can be something like losing a job.
Absolutely.
Or having a relationship end badly.
Absolutely.
Quarantine.
I do have a sub agenda.
Yeah.
Because we are also noticing, this is a side thing, but one thing that's becoming increasingly clear from, sort of our observations, but also a lot of the people studying disinformation, is that people who are experiencing some level of psychological stress, anxiety, trauma are far more susceptible to disinformation than other people. It's a risk factor, and in fact, not just susceptible to disinformation, but also people who study radicalization. They say the one thing that nearly all of them have in common, it's not race, it's not socioeconomic, it's not education, it's not upbringing, but at some point they experience some kind of trauma. So it's just interesting to me to sort of see how these things start to connect. I want to get back to something that Kristin was saying, that, and you were also alluding to, Shantae, that one of the ways, because the key thing here is fear, this and a very real mistrust of authority, mistrust and sort of an expectation of judgment and not feeling good enough, whatever, in a doctor's office. But I'm going to cheat and think a little bit even more broadly than that. You do what you can to put people on an equal plane and put them in power. You take off your symbols of doctorness, your lab coat, etc. You ask them questions about themselves. I want to, talk more about how you show that curiosity, how you show that respect, and how people respond to it.
So I could start on that. I think a lot of it is just asking lots of questions and noticing and being observant. Is someone sitting very closed in and hunched over? Do they flinch when I touch them? Are they only giving me single word answers? If there are those signs of fear or resistance or triggering signs, to step back and say, is something bothering you? Is there something that I'm doing that's making you uncomfortable? How can we make you more comfortable?
So this is something, it's not just when someone has suffered serious abuse, you practice this for anyone who walks in your door.
Correct. Absolutely. Absolutely. Correct. So there is a sort of a movement in this concept of trauma-informed care to make it universal. Right. I don't have to know that someone has trauma to be able to, or know what that trauma is, to be able to treat them, respectfully and give them back power. Right. So yeah, very much like in the 80s, the healthcare community moved, or with the onset of HIV, to moved to universal precautions with personal protective equipment, by saying that, hey, you can't look at someone and say, oh, you have HIV because of the way you look. Therefore, I'm going to wear gloves. Or you don't have HIV because of the way you look. Therefore, I don't need to wear gloves. You can't look at someone and say, you've got trauma. In order to give respect and to not trigger and to partner, as opposed to being the doctor down kind of language, you want to make trauma-informed care a universal language.
So you're almost thinking about changing your own role.
Yeah.
Well, it's patient-led care, right? So it's holistic, meaning I'm not just looking at you physically, I'm caring about your whole body. I'm caring about where you are emotionally, I'm caring about where you are mentally, I'm caring about where you are spiritually, I'm caring about where you are physically. So it's holistic and it's trauma informed, but it's also patient led. So it's less of the, it's giving the permission to say no to a question. It's giving the permission to say, no, I don't want to do this today. Or yes, can we do this today? It's having a conversation with the understanding, like, yes, though I am the practitioner, I have this knowledge, I have the direction in which this is what we're going to focus on, so I can help you in that direction. But I'm not walking through the door telling you to sit down on my table and then telling you everything else you need to do.
Sit down on my table, take off all your clothes, and tell me all your secrets.
Right.
Pretty much. The one thing, that we also talk about in trauma-informed care is that I'm not looking for disclosure, right? I'm not looking for you to sit down and say, this is what I've been through and tell me, your whole life story. Now, if that happens, we are respectful of when that happens. But in treating anyone who walks through our door universally, it's having the practice of saying, this is who we are. This is who we want to be. We want to be a safe place for anyone who walks through our door, whether you have trauma or whether you don't.
So that's really interesting. And so I'm inferring a few things here that I would like you to, I want you to ask you the questions so that you make them explicit, because I want to make sure I'm not inferring more than I should. When you have that patient with high blood pressure, and they don't want to take care of it. They don't want to take medicine. They don't want to talk to you about it. It's, for whatever reason, they don't want to. What is your goal in that conversation?
So my goal is exploring the why. So if a person comes into my office, they're here because they're seeking some sort of help. Right? And so if they have high blood pressure and they don't want to treat it, I'm going to go more, and this is where the holistic portion of that medicine comes into, why don't you want to treat this? Talk to me about your family. Who is it in your family that you love? Who is it that you enjoy being with? Do you understand that, if your pressure isn't treated, you may not have this relationship the way that you think? What is it? Have you taken medication in the past? And so it's finding out the why to the resistance. And a lot of times people treat resistance as just a blockade and somebody being difficult. If someone's in my office, then again, I know that they're here because they want care. And if the care in which I'm offering is not what they want to do, then I feel as though it's my job as a practitioner to find out why. Because there's a reason why they don't want to take that medication. They're not just to me, there's no such thing as a difficult patient. A person has their perceptions and a person has their beliefs based on something that has happened to them or based on something that has happened to somebody in which they've loved and had a negative outcome. There's something there that's keeping them from saying, yes, there's something that's making them either not trust me, not trust my decision, or there's something in their own experiences that makes them not want to do that. So my job is to find out the why and then work with that why. My job is not to tell them, well, this is what you're going to do.
So, and oftentimes that those answers can be disinformation.
Right.
It can be, well, my uncle's brother said that if I took this medication, I would grow hair on my back, or or whatever, and they believe it, and it is, and they love and trust that uncle, and if the uncle said it, then it's golden.
Right.
And
you're speaking to my the heart of my interest here.
Yeah.
And let's just sort of be explicit. When we're talking about vaccine hesitancy, I imagine you have met a couple of people who do not wish to be vaccinated against COVID recently.
Yeah, yeah.
How do you explore that? Where have you made progress? Where have you not made progress?
So just sort of tagging back on the approach to someone who's resistant. A lot of that goes to motivational interviewing concepts, which has been something that's been focused on a lot more in the social work field, in the counseling field, than in the medical field. But the medical profession is slowly catching up, I think. And we're always a little slow on the uptake. But yeah, it's that getting to what motivates people, and are they motivated by being around for their grandchildren? Are they motivated by looking good in a bikini? Are they motivated by, what are the motivations that turn someone against or for a decision? And then building on that. And but as far as vaccine hesitancy, I mean, I have definitely seen a lot of disinformation, and there's only so much that corrective information can do in the face of disinformation, because again, I may not be the trusted uncle with the story, and but you can challenge that information, not necessarily disprove it, but say, hey, I'm glad you're thinking about this. This is this is great that you're putting thought into questioning, that you're not just accepting something point blank. That shows real power, that shows personal agency, that shows that you're using your brain, and that but then I would then go on to challenge the same hesitancy and questioning that you're giving to someone saying this is good for you. Put that same questioning to someone who's saying it's bad for you, and and not to necessarily weigh one way or the other, but to say, don't put blinders on when your uncle's talking. Take those blinders off. And do they have ulterior motives for telling you what they're telling you? Or is their story correct? Or is it something that they heard from someone else, and it's a whisper down the lane kind of situation where the original story was so different than the final outcome? And
you can still love your uncle very much and disagree with him on this point.
Absolutely. But just to use that same critical thinking and apply it on both sides.
Validate what they're doing and how they're thinking and their concerns, and then invite them to think a little differently. Ask them additional questions about that. That's
well, I was going to say it's welcoming a conversation, right? It's welcoming somebody to say, well, what are your concerns? Let's talk about your concerns. Let's talk about the validity of any of those concerns. And then let's see if we come to a resolution. But at the end of that resolution, it's still not me saying, well, now you have to do this. The choice is still yours. You know, and I think that's the important piece of it. Even with disinformation or anything else around, I can disprove, you know, or I can say, well, you know, and I can say medically, you know, what's sound and what's not sound because, right, we're educated, right, in the medical field for whatever we do know. You know, because
Today.
Obviously, exactly today, because it's always evolving and always changing, and God knows we do not know everything just because we're practitioners. But, you know, there are things that I can say, no, if you take this blood pressure medication, you're not going to grow hair on your back, right? So there are things, certain things with disinformation I can say, and then there are those gray areas where there are times I do have to say, you know what, I don't know. You know, I don't know. But if I'm looking at, you know, benefits versus risks, these are, and that's the importance behind informed consent, right? Giving someone all of the information that they need to make a best choice decision for themselves. And so then whether I'm educating them on, again, whatever those misbeliefs, you know, truths may be, or if I'm educating them on whatever knowledge that they're looking for, at the end of the day, I've informed you. It is now up to you to make that decision. I'm not saying, well, now you have to do this, because then it's right back to, well, even though I gave you all of this information, I'm still telling you what to do.
I actually have a question from, well, this is something that you guys have talked to us about in terms of like policies and protocols that you've wanted to put in place, but you've actually talked to the US government specifically about what vaccine hesitancy looks like in terms of people who've been traumatized.
Yes.
And what were some of the specific languages and protocols that you asked, that you said, hey, this could possibly work a lot better? And what are some of the triggering things that have been going out in terms of the messaging that might reinforce some of the mistrust? So like those two things would be.
Yeah, language is so powerful, and you know, how we phrase things and how we present things and how we talk, and you know, it makes a huge difference on triggering someone into resistance, but as opposed to opening them up to possibilities. And certainly something that words that are triggering for someone who has been traumatized are mandates, are you must do this, you're required to do this, this is you don't have a choice, and removing power and choice, basically. The you know, the alternative to that could be really you know, in the realm of masking, for wearing a mask, is not you know, you're required to, and it's something that you have to do, but it's something that you have the power to protect. This is the fact. The fact is that this virus is, you know, lives in can live in your mouth and your nose, and that if it's very contagious, and if you speak it or cough it or sneeze it, someone else can get it. And so it's within your power and your privilege to protect your neighbor and to protect your family member, and or to protect a stranger, and that you can feel, that's something you can feel good about, that putting on that mask is actually, you know, helping and is showing your concern for other people. And, you know, some of that goes with vaccine as well, because as we reduce the ability of the virus to replicate, there's less chance for mutations, and there's less chance that we're going to get a strain that is resistant to the medications that we have, or that's more virulent, that or more toxic than what we already have, which is pretty bad. So when you're talking population health, the more people who get vaccinated and have antibodies and are not a source for the virus to replicate, the less chance it's going to spread. And
We don't do this for the
so-
government, we do it for each other.
Right. Yeah, we're not doing it for the big pharma to make lots of money, which of course they are doing. But we're not doing it for the CEOs. We're doing it for our loved ones. And, it's a power that we can choose to protect ourselves and to protect our friends and family.
While we were talking here, I just got a notice that said Dr. Fauci said this, that fully vaccinated people don't need to wear masks anymore, indoors or out. I'm hoping it says something that says yet except in public. But
Sorry.
except in public places. I hope there's still a public places recommendation.
Right.
But there's a lot of good that there are benefits, like fun stuff happens for people who get vaccinated. You can see your friends, you can see your family.
But that's also control.
Right.
That's also control.
Right.
That is saying, if you do this, you get rewarded with this. And if you don't do this, then you're going to get punished by this.
Right.
That's still not okay.
So I have a couple more questions for you that I want to get to, which is, it sounds to me that the core of what you are advocating is a lack of judgment, a curiosity and openness, a putting people in control of their own decisions. And that this is extremely important in the realm of people who are suffering trauma. But it feels like that also is generally a good thing in general, in medicine as a whole, and maybe outside your clinic. Can you talk about how does being a practitioner and a student and an advocate for trauma-informed care inform your worldview and your relationships overall?
I think it just comes down to understanding people and not being judgmental, and understanding that, again, people, you never know the path in which someone's life has led them. It's very easy for us to look at someone and be like, oh, well, you're there because of this and because of that. And that's our own preconceived notions and our own judgments that we have, maybe our own cultural biases that we have. But it changes my worldview, or it changed my worldview, right? Because I didn't learn this in PA school. There was no trauma-informed care class in school, but it was through my experience of working as a sexual assault examiner, through my experience of working internationally with trafficking survivors, and then working here with trafficking survivors, that as I listened to people, as I listened to their stories, and even reflecting, knowing my own story and how I grew up, in an inner city ghetto, with single family, drug infested. Do you know what I mean? Like knowing, and to look at where I was then and where I am now, understanding people's threads of their life is not linear. And so many times we look at people like, oh, well, you did this, so that's why you're here. Not realizing that someone's life is going to take so many twists and turns to get to where they are, that if I don't stop and just listen, observe and listen. But we're such a society that just passes judgment, right? We don't want to listen. We don't want to take the time to observe, but we're quick to pass judgment.
And the complicating factor with that is that listening takes time.
Correct.
And,
Correct.
It's way easier to pass a mandate than it is to listen.
Right.
And especially when you're talking getting word out to the masses or
Right.
whatever, listening to every individual story and
Right.
And all of that is time intensive
Right.
and effort, and we're in such a 20-second infomercial life with social media and everything else, that it's almost a lost art.
Yeah.
Yeah.
You know, because there's also, right, when you talk about vaccine hesitancy, there's also the other side of vaccine hesitancy, right? There's a side of those who don't want to get vaccinated for whatever their reasons are. But then now they're judged and they're looked upon like, well, you don't care about your loved ones, you don't care about your family, you don't care about society. And that may not be true either. That's also a disinformation that people have. And so there's judgments on both sides of that screen. Vaccine hesitancy, even just that word, even just saying, well, you have vaccine hesitancy already puts a negative condemnation on me. It's already saying there's something wrong with you, right? So again, the language that we use in general, no matter what side of that you're on, is all about being willing to stop and listen to what that story is and being able to communicate why it is you're on either side of that fence.
And that's one of the biggest problems that we're having in terms of, like, to bring it kind of back into our realm of disinfo, is that the quick snap judgments are very easy for us to make. So for those of us who are, you know, who we're like, oh, we have these facts, we have this knowledge, and we understand what's going on, it's very easy for us to be like, oh, that person just, it doesn't understand, or they're just dumb, or they're just, you know, they're undereducated, or all these factors and judgments that we put on them, because they don't necessarily share the same worldview as us.
Right.
So and then you amplify that by 1,000 by being on social media, where you hear every opinion you have kind of echoed back at you because of the way the algorithm works, that you are just in this bubble of, well, everybody thinks like me, so the people who don't have lost their minds and they're all crazy, instead of, and that's one of the best things about learning these protocols has been for me, is because now when I see something that someone writes or someone says that's, I think, clearly founded in some crazy disinfo, you know, my thought process isn't, wow, this person is so dumb or so, or maliciously doing this. My thought process goes to, what makes them think that this is real, or what is going on in their life or in their narrative that has caused their worldview to be this, without the judgment of, well, this is blatant, like, this is wrong. It's just, what is that worldview? What is that perspective? And so it makes me a little bit more careful as a writer, as like a person who's saying, like, okay, now I'm not coming at this from, I need to just feed you what I think is right. It's like, no, I need to understand where you're coming from so I can speak directly to that, instead of, you know, just pushing out what my narrative is.
And Rachel, I just want to add on to that, because you said a few very key things, right? The first one is opinions. When we start taking opinions for facts, right? So in our social media world, in our Google world, we're just looking up opinions, and you're getting fed opinions, and those opinions at whatever point starts translating, oh, into this is fact, right? So that's one huge area of that disinformation, right? Is that people are thinking, okay, well, if everybody's opinion is this way, then it must be true.
Yeah.
But the other side of that is, as a society, we've moved away from just critically thinking. We're used to being fed, right? We're used to, let me go on again, this, you know, my 20-second mind, you know, span, let me go on and let me just get a quick answer. Let me go on and see what somebody says. Let me go on and see what somebody thinks. We're no longer taught in general to stop and let me think about this decision for myself. Because
how
so
do
many
you encourage critical
being
thinking?
fed to us, or they're being forced upon us. And when you're talking about somebody who has experienced trauma, that has been their life. They have had to either force to accept what someone has to give them, or they've been denied the access to think for themselves.
Right. And that's really what I think, kind of, when it comes to my writing, or when it comes to what we're doing in terms of a reality team, I think we've tried to set a really clear agenda of, I'm going to present you with as many facts as possible. Like, this is completely objective. This is what this is, you know, but it's not with the intention of, now I'm going to persuade you how to think about it. It's with the agenda of, now I've given you access to some information that you can have a critical thought process about, and encouraging that thought process. And you may or may not come out with the outcome that I think you should come out with, but it's still, at least you have the facts, you know, like what's actually objective, not an opinion. Here is what this is in terms of science. And that's where I think we're running into like a big issue, is because of the fact, like you were saying, people are taking opinions and turning them into facts. And so now the real fight turns into, how do we separate what is a real fact for people from what is an objective opinion?
Well, I think that you guys have created a lot of space in there too, which is, first of all, when we started Reality Team, we were a little angry. And like, it was very hard to keep that anger out of what we were doing, but we have grown through that. And to, as you were saying, both empowerment and encouraging critical thinking is both about being curious and asking questions. And so now, more than sort of facts, just sort of, first of all, understand what people are actually worried about. When you hear a certain piece of disinformation, it's ringing some kind of bell, right? It's ringing some sort of fear. Having respect for what that might be. But what you're talking about is obviously how to talk to people who are fearful for reasons, right? They're not just crazy people, right?
Correct.
But fearful people in general, first of all, you don't know where those fears come from.
Correct.
Second of all, does it really matter? Does it really, instead of caring about why they're afraid, creating that opportunity for them to think, to be heard, to be respected. And you were just saying, Shantae, about encouraging critical thinking. Those same kind of questions, that same kind of curiosity also does that. In addition to showing respect, it also encourages critical thinking. Or I'm putting that out there. Does that feel right to you as well?
So you're saying that in asking someone why they have the fear is.
So you were talking about motivational, or Kristin, you were talking about motivational interviewing.
Right.
Shantae, you were talking about, you know, how you might encourage someone to question their trusted uncle, or sure. Maybe I got that reversed.
Yeah, it's up.
You are not only showing that you care who they are as a person, you are not only trying to understand the motivation, but you are also encouraging them to do the same thing.
Yes. Yeah. Yes. 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 Because a lot of times we need to understand our own motives. We need to understand our own actions. We need to, like, it's easy for me to say, you know, I had this experience, and this is why then when something triggers me, I continue to have this experience. But it's also understanding that my body has a memory for that trauma, right? So once I understand that my body's going to have a propensity, like just to go back to the car accident, every time I get into the car, I'm going to get stiff, I'm going to get nervous, I'm going to drive because of my previous car accident, then I can begin to tell myself, okay, well, I know why this is happening, opposed to every time I get into the car, I don't know why I'm nervous. Right? I'm just nervous, I'm just upset, I can't drive, and I'm concerned. And so to me, I'm like, I can't drive. That's it, I can't drive. I'll never drive again because every time I look at a car, I'm nervous, right? But if I understand, and now I'm thinking I'm crazy, right? I'm crazy because that's it, every time I look at a car, I'm nervous. But once you begin to understand the why behind things happen, then you can explain. And if once, see, there's a difference in asking what and why. When you're just asking what, you're just looking for an answer. When you're asking why, you're looking for a solution. And so when you look for a solution, you can find resolution.
This has been a really interesting conversation. And I think that there is a lot to be learned here, not just about understanding where certain kinds of distrust are made, not just understanding the relationship between racism and worries about vaccines and trauma, but also in how we can change the way we view each other, how we can be curious about our world, and how powerful that is in building trust, empowering people, giving people their own agency to make good decisions.
Absolutely.
Yeah.
I'm going to let you go. I know we all have some places we need to go. Thank you so very much for your learning. I'm going to pester you in a follow-up for some resources on where to learn more about trauma-informed care, and some of the suggestions that you sent in terms of messaging around vaccines that I think would be interesting to publish more widely. And again, thank you very much, Rachel. You're an awesome human being. Thank you for
Yes,
They're rock stars.
creating this conversation. And thank you everyone who's listening. If you have questions, send them to us and we will get answers for you.
All right.
Bye.
Thank you. Thanks. Bye.